Welcome, and thank you for joining us for today's webinar on Expanding Indication for Transplant Oncology, Living Donor Liver Transplantation, and Unresectable Colorectal Liver Metastasis. Before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed on your screen. Please take a moment to answer this question while we finish the remaining announcements. This webinar is being recorded and the archive will be available in 4 to 5 business days. Please note that all of your lines have been muted so that only the presenters can be heard for the archive recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A window in the Zoom webinar panel to submit your questions for consideration. Questions submitted via the chat section may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline or post the full question with the answer on the hub following the presentation. Finally, at the conclusion of today's webinar, a short survey will appear on your screen to complete. Please fill out this survey to help us keep our content current and engaging. I now turn the session over to our moderators, Dr. Anjana Pillai and Dr. Alexandra Shingina, to begin our presentation.
Hi, everybody. Thank you so much for the introduction, Brian. And it's my pleasure to co-moderate this webinar with Dr. Anjana Pillai, who is a professor of medicine and a co-director of Living Donor Liver Transplant Program, medical director of the Liver Tumor Program, and director of Transplant Hepatology Fellowship Program. So we have a stellar lineup of speakers today with unique expertise in expanding field of living donor transplant for colorectal metastasis. As we all know, transplant is the ultimate multidisciplinary sport, and this particular topic really involves even more collaborations and multifaceted discussions. And so we tried to tailor this webinar to capture the point of view of multiple disciplines involved in care of these complex patients. And so, as you can see, our webinar will consist of 3 parts. We will include the point of view of a transplant professional with Dr. Roberto Hernandez, who will discuss published experience of liver transplant for colorectal metastases and programmatic approaches and best practices. This will be followed by a presentation by Dr. Cathy Eng, who's an oncologist, on overview of recipient treatment, indications, and protocols for liver transplant planning. And then we will follow up with an ethicist point of view by Dr. Carrie Thiessen, who will talk about ethical issues of living donor liver transplant use for high recurrence disease. It is my honor to introduce our first speaker, Dr. Roberto Hernandez, who is the Chief of Division of Transplantation at the University of Rochester and Professor of Surgery since August of 2016. He was recently named the Director of the URMC Transplant Institute. He completed transplant and hepatobiliary surgery fellowships at Western University, Canada, and subsequently received further training in the living donor transplant in Kyoto University in Japan. He has been successful at developing one of the largest programs for the liver transplantation for unresectable colorectal metastases in the United States, and has published over more than 150 peer-reviewed publications in the area of hepatobiliary surgery and liver transplantation. And in 2019, he began his tenure on the editorial board of Annals in Surgery, one of the highest impact factor journals in surgery. Dr. Hernandez, I turn it over to you.
Thank you very much for this introduction. This is a pleasure for me to be here. Thank you very much, Dr. Alex, for the kind of introduction, and a pleasure for me to be part of this webinar through AST. So this is a very interesting and hot topic, I would say, which is liver transplantation for colorectal metastasis. And this is not only increasing the interest in the United States. I can say all over this world, there's a lot of interest. And the United States has been taking a substantial bite on this area. And it's not only the interest, the activity is growing. And I will be sharing with you some of these points that I'm discussing. I have nothing to disclose in regards and related to this presentation. I want to show you the impact of colon cancer and rectal cancer. As you can see here in the right side of your screen, the incidence of colorectal cancer has been decreasing in the elderly ages, in the 80s, 70s, and if we see the 60s and the 50s also is decreasing. Probably is plateauing in the mid 40s. Why is this? Is because I think we're doing a good job on doing colonoscopies, prevention medicine. But something is happening to the younger populations in the low 40s, 30s, and even 20s, that the incidence is increasing, and this is happening more often. There's a lot of research about this, why this is happening, if this is environmental, if this is what we're eating or drinking, probably is related to that, but we're not here to discuss that. So the problem is that this is increasing in younger population, and this is the third most common cancer in the world, and in the U.S., around 150,000 people are diagnosed every year, perhaps 2 million internationally. And the half of these patients will develop liver metastasis at some moment. So what options do we have? I know that they're going to be talking more about this later on, so I just briefly description of this. We have chemotherapy and biological agents. We have the most common ones that are FOLFOX and FOLFIRI that are used, and some biologics that enhance the treatment of chemotherapy, depending also in some of the characteristics of the tumors. We have biomarker-driven approaches as well, specific for some mutations such as BRAF, HER2, and also we use local regional approaches. This is most likely when there's liver dominant disease. We know that majority of the time this is a systemic disease, but when there's liver only or dominant disease in the liver, we can do liver resections, ablation, hepatic artery infusion, arterial pump, Y90, and nowadays another hot topic that is histotripsy that I think is going to start increasing the interest of the oncological field. So important thing here is we're talking about unresectable liver metastases. So when we call unresectable, the vast majority of the time is because there are multiple metastases in the liver. And this is a liver met survey from 2023 European, where they were able to analyze more than 27,000 patients. And the number of liver metastases is after resection is associated with survival at 5 years. So if you have 1 to 3 liver metastases and go for resection, your chances of surviving at 5 years is around 76%. Compare when it's between 4 and 7, that is only 16%, or when they're more than 7, there's 7% survival at 5 years, and this is after resection. We have expanded our opportunities of doing liver resections with more techniques, two-stage hepatectomies. We do ALPS procedure, ablations, but despite that, the outcome of these patients is not the best. And we can see here what happened to these patients. They have recurrence, and recurrence in the liver is what really affected the survival of patients when they go for resection and they have early recurrence in the liver. So those patients, you can see here, overall survival, when they have early recurrence, the outcome of these patients is going to be pretty poor, and it's associated with a bad outcome. So when we talk about unresectable liver metastases, this is a very good example, this CT scan, that it's impossible to do liver resection. I have the opportunity, as they mentioned, of being trained in hepatobiliary surgery. I try to be as much as possible aggressive for liver resections, but this case is unresectable. The 5-year survival of these patients only in chemotherapy, it's around 5 to 10% according to the literature. Now, liver transplantation is not a new thing for colorectal liver metastasis. In the late 80s and early 90s, there was a lot of interest in 2 countries in Europe. One was Austria, and the other one was France, where they did liver transplant for colorectal metastasis or unresectable disease. And at that time, they were also doing it. I was not aware of these. They were doing some intraarterial chemotherapy, different way that is right now. Of course, the chemotherapeutic agents that they use in the late 80s and early 90s are not used anymore. And we have advanced a lot, but the outcome was, despite they saw that there was an advantage of liver transplant, compared to intraarterial chemotherapy in patients with unresectable disease. It was minimal, but it was decided that this was an unresectable disease was a contraindication for liver transplantation. So it was abandoned. But what happened in the last 25, 27 years after that? So I think we have learned a lot in the field of oncology, in the field of cancer. We know clearly that the size and number of the tumors matters. We know about tumor markers such as CEA, which is one of the best to predict. Not all the patients elevated CEA, but it's a good way of knowing the response and recurrence of patients. Nowadays, we have circulating tumor DNA. There's 2 companies that are working on that. And we work and do that in our patients for resection and liver transplantation. We know that the response to systemic chemotherapy, it's a good sign of to understand the behavior of the tumor, the presence of not of extrahepatic disease, when they are retroperitoneal nodes or perihepatic nodes, and of course the mutations. Nowadays, we're doing a lot of work on this. We have learned a lot from people from, for example, in MD Anderson, where we know more about the different type of mutations like BRAF, KRAS, RAS, TP53. All of these things is what it has changed over the last 2 decades. We have clinical factors that are able to measure the tumor biology. And when we measure the tumor biology, we're better to understand and to select the patients who might have a better outcome. So this is why Norway started doing liver transplantation for colorectal liver metastases, and they revisited the possibility around 13, 14 years ago. And not only because of this, also we have better surgical techniques in liver transplantation, plus better immunosuppression. So the advances and the progress in oncology, immunosuppression, better techniques. And they did these transplants only in 21 patients, their first trial, and they were able to show 60% survival on unresectable disease after transplantation. This is much better of what we saw, 5-10%. However, the recurrence was practically universal in this population of patients. But it was a pretty broad spectrum with just few weeks of chemotherapy and not a very detailed workup. But this is when they did a second trial, coming to a more criteria. They developed this Oslo score, where the more points, the worse the outcome, the less points, the better the outcome. And they look at their multivariate analysis, and those tumors, metastases, if there was one bigger than 5.5 centimeter, it was a bad prognosis, or a CEA pre-transplant above 80, or if the patient was progressing under chemotherapy, or the interval between the diagnosis and the liver transplant. So we can see here that if you have an Oslo score of 0 or 1, survival at 5 years is 100%. However, we have to be cautious with this. This was only 16 patients, and 6 of them were qualified for 0 to 1. But this was pretty interesting to see that there were some patients that perhaps could be cured. Later on, they developed this very interesting use of nuclear medicine scans, where they developed the MTB score, the MTB of above or below 70 centimeters cubic. We adopted this at the University of Rochester, and we look at this in all our patients, and we check about the ability. There's a formula that is describing this paper from the group from Norway, where we can analyze the uptake and the ability of the tumors. And if it's more or below 70, you can see here the significant difference in survival of these patients. So this starts spreading in North America. There was a lot of interest. There were 3 institutions, including Cleveland Clinic, the University of Toronto, and University of Rochester, that we started doing this in living donor liver transplantation. In Norway, they have the capacity of doing this with deceased organs because they have a short waiting list for their patients with HCC and cirrhotic patients, and they have kind of the waiting time there is 30 to 60 days for getting a liver transplant when you're listed in Norway. In the US, we know that it's completely different, and probably in Canada as well. So we can see here that our group with Cleveland and Toronto, we published this was the first 10 cases doing with living donor liver transplantation with a pretty acceptable overall survival and recurrence-free survival, but this was only at 3 years because it was too early experience. It has spread to other places in the US. And in 2017 to 2022, in March, we analyzed with Kazu Sasaki from Stanford and some of my group here, we were able to analyze the SRTR database. And there were 46 patients transplanted at that moment. We look at the probability of survival. And as you can see here, it's a little bit above 60%, which it's a little bit low compared to what Norway was presenting. That was a little bit of concern. And interestingly, the outcome of those who has a living donor was a little bit better or way better than deceased organ. We unfortunately, SRTR database is not an oncological database, so we cannot know about details of the selection of patients. Is this the selection of the organs or is the selection of the recipients? What is affecting this outcome, whether it's disease or living donor. But I have this update slide for you that it was until March of 2024. So this is pretty recent. And you can see how it is increasing the number of liver transplant in this country for colorectal liver metastases. The vast majority are done with living donor. Last year, there were more than 35 cases done. And I think this year is going to be even higher. And we analyzed recently, we haven't published this, but we're working on a paper showing that the overall survival, it improved 65% at 3 years. Disease-free survival, 50%. I am not sure if this is a correct number. If this is 50% at 3 years, I think it's pretty good. I would expect to be lower, but I think we don't have a very detailed workup for our patients in SRTR. Now, when we divide and try to analyze living donor and deceased donors, we can see again that there's a substantial difference. It was not significant, probably because of the N number, but 74% survival at 3 years compared to 54 when it's a deceased organ versus a living donor. So that is important, and this is something that we need to understand and learn more about this. Well, that is why we put through ASTS a task force for liver oncology, which I've been working with Talia Baker from Utah, where we are trying to engage different institutions that are doing this. We know who are the institutions who are doing liver transplant for colorectal metastases. We have been working, and the house of this registry is in University of Rochester, and we are getting different steps, and we have completed around 40 patients. This is not updated. I think we have a little bit more patients already in our data, and hopefully we can have some multi-center studies soon. Around 5.5 years ago, we started this protocol in University of Rochester. We were doing liver donor liver transplantation for cirrhotic and HCCs. So it was not that difficult to adopt this for our patients with colorectal liver metastases. And we don't follow exactly the Oslo score. For example, for us, even if it's only 1 point and the CEA is about 80, it's a contraindication. If the patient is the only point in the Oslo score progression on chemotherapy, we believe this is a contraindication. So we kind of see some of the important things, but we've made it a little bit more strict because we want to be sure that we are able to have a good outcome. Those patients with mutations such as KRAS wild type or combination with TP53, or patients who have a tumor in the right side of the colon, which has worse prognosis, we observe them for a year and a half instead of 1 year. We believe that it's better to understand the behavior of the tumor. So far, we have done 24 of these transplants. To my understanding, we're the largest center outside Oslo, in North America. We, at that moment of May 2024, we evaluated 225 patients, and we have the appropriate follow-up of 20 for less months. This is where Rochester is located. And the green points that you're going to see here are where we have patients referrals from a lot of other places. Not that many come from the Rochester area. Majority come from outside New York State. And a lot of patients, for example, here in all the East Coast that we have, and many of them from California. And this is where the arrows in red demonstrate where the recipients came after follow them up, a lot of them through telemedicine. And in blue is where their donors come from. Some of them even from Canada, from Ottawa, Toronto, and Vancouver. The 3-year follow-up overall survival, we have 90%. I hope this continue to be like that. That's not going to be true. I think it's going to start having recurrence and it start coming down slowly. Patients with recurrence, we have already 2 patients with recurrence. Sorry, not two patients who die, and we have around 4 or 5 patients who have a recurrence and continue to be alive. This is a paper where our research resident just published. It was accepted in JAMA Surgery, where we look at progression-free survival. And what is interesting of this paper is, of 62 patients that we believe they were eligible when we assess them, if I would have a liver in that moment, I will be transplanting them. Of those ones, 20 got a living donor. But 13 of those patients, they decided themselves not to come to Rochester, to go to other places, to have alternative therapies, to get more chemo, to get pump, other type of. And then we were able to follow those patients because there's a way of following these patients, and 70% progression in just a few months. Only 30% didn't have progression, compared to no evidence of disease in this follow-up of 75% of the patient. This is not a randomized trial, but I think at this moment is the highest level of evidence of 2 populations of patients where they are exactly similar, that with transplantation, you do much better than with other alternative treatments. And these are the survival. It was not significant, as you can see here, but the progression-free survival was pretty significant here. An interesting thing that I want to share with all of you is what we have found. This is Mariana, our fellow that now it's going to the Mayo Clinic in Arizona for clinical fellowship. We analyzed 14 cases where the column in the left side of the livers are when the patients were diagnosed with liver metastasis, the imaging. Then the one in the middle is the one of the imaging pre-transplant, just before transplant. And the brown livers are the explants. And we were able to, when we analyze and compare tumors, that 64% of the patient were found to have undiagnosed metastases. This is clearly showing that the vast majority of the time, there's more disease of what we can see in the CT scans and MRIs. And this is an example. You can see this patient here with multiple metastases. Probably some of my colleagues, aggressive surgeons, we can say, oh, you know, these patients have the segment 4, no tumors. Maybe we can do a 2-stage hepatectomy and ALF procedure. The patient received chemotherapy, and impressively, look how the patient responded. And this is, you can barely see some of the metastases in the left side. Someone will say, okay, do a right posterior segmentectomy and maybe some ablation here in the left side. So we ended doing a transplant in these patients. Why? Because we understand that this is what they have. We couldn't see these tumors even in MRIs. And these are the multiple tumors that these patients show. And this is part of the study that I showed with you. Now, what is the evidence of long-term outcomes? More than 10-year survival here is showing by the group of Norway in their SEICA-1 trial, where they were able to show around 40% survival. So pretty good and acceptable outcomes that we can see in these patients. Interestingly, the survival after relapse is pretty good in these patients. Many of them, they don't have recurrence in the liver. They have recurrence in other organs, such as the lungs, and not necessarily the patient needs to go back to chemotherapy. And we can discuss that in the questions and answers later on. And this is just to show you some data that we have. Liver transplantation recurrence, it's lower in the liver because there's a new liver, and there's probably in the resection area, when we did resection, there were micrometastases that they will come back. And it matters where the patients have recurrence. When there's recurrence, and this is data from liver resections, in the liver, the outcome of the patient is poor, the survival. When there's pulmonary recurrence, the survival of the patients is much better. And just to show the highest level of evidence, this is what the RCT that was done, that everybody was waiting. And this is the group from René Adam in Paul Bruce in Paris, where he analyzed 94 patients that were enrolled, 47 were assigned to transplantation with chemotherapy and 47 to receive only chemotherapy. And what is so interesting to see here, the intention to treat, because some patients didn't reach transplant who were in the arm of transplant, it was significant, the difference, as you can see here, between the two groups. It was pretty impressive to see this. Now, for me, the survival as proper protocol, you can see how evidence is here. This is below 10%, and this is close to 80%. Yeah, and it is statistically significant. This paper is on revision right now. I'm using these slides because it was presented at ASCO, and I took these pictures from that presentation. And the progression-free survival of these both population of patients in this randomized control trial, it's shown here with the benefit, substantial benefit with patients who have liver transplantation. So for me, this is the highest level of evidence. And just to, I think as a community here, ASTS, AST, our hepatologists that are very important for us here in the what I call the field of hepato-oncology, we need to come together and define what is the metric, where should we trace the line about what is okay for survival, what is okay of recurrence, because if we compare this to recurrence in the HCC, it's very different. We have around 75% of the patients will have recurrence in colorectal metastases compared to probably only 12, 13% in HCC. But if we see recurrence in alcohol, it might be also different. We need to come as a community to decide what is good for these patients. In the meantime, living donor liver transplantation is helping many of these patients. I know that some of them are getting organs from POMs or extended criteria or DCDs, which is okay. I think it's okay as long as there are good organs, not very marginal organs, because we cannot understand if the cause of complications or death or recurrence could be affected by these type of organs. So with this, I think now that ASCO presented this, we're going to start having more influx of patients. The population is going to be pretty big into this area. To conclude, liver transplantation can provide substantial survival benefit for patients with colorectal metastases. It's very important to understand and reflect the tumor biology. I think we have to work very close with our medical oncologists and surgical oncologists. Early referral to transplant oncology centers is a priority, and communications with the oncology and the transplant team is very important. The multidisciplinary management is key, and to select the patients. And I personally think that the early access to liver transplantation is crucial in this population. Whether you do it in Norway, like with a lot of diseased organs with good quality, or with living donation, what we need to do is to have early access for transplantation. And with this, I conclude. Thank you very much.
Thank you, Roberto. That was really excellent overview. Really appreciate that. While we're waiting for Dr. Eng, who's our next speaker, I want to introduce her. So we're very happy that Dr.
You are viewing Cathy Eng's screen.
Sorry about that. We were very happy to have Dr. Cathy Eng, who is a professor of medicine, hematology oncology, in the David H. Johnson Endowed Chair of Surgical and Medical Oncology, as well as the co-director of GI Oncology and several other leadership positions at the Vanderbilt Ingram Cancer Center. Dr. Eng currently sits on the board of directors for the National Patient Advocacy Group, Fight Colorectal Cancer. She has multiple leadership positions in the development of phase 1 to 3 trials using novel therapeutics for biomarker discovery and enhanced drug utilization in colorectal, appendiceal, and anal cancer. And impressively, she was awarded the BUMC Biomedical Scientist Impact Award in 2023. She has published in many peer-reviewed journals and is highly active, serving on many leadership committees in ASCO, ECOG, and SWOG, and also has been chosen as a fellow of the Executive Leadership in Academic Medicine, class of 2002. So very excited to have her. We gave a really hard topic. So she is going to be talking on overview of recipient treatment indications and protocol management in colorectal liver metastases.
Well, thank you for inviting me to participate today. It's my pleasure to participate in this really exciting discussion because it is a very hot topic. And there's my contact information for those that follow on social media, etc. So I made my lecture very broad because I am a medical oncologist. I am not a transplant surgeon. I'm not a surgeon or a gastroenterologist that does transplant focused. But obviously, because I treat colorectal carcinoma, this is a very exciting topic for consideration. So these are my disclosures. So what I'm going to be touching upon just very briefly, because I was given 15 minutes, is really to just discuss what would be considered in the setting of potential protocol development based upon what is available to us in the literature currently. So I wanted to discuss both historic good and poor prognostic indicators. I'm not going to be elaborating upon all the various trials and all the various molecular subsets, but only a couple particular molecular subsets, and then how you may want to develop a clinical trial for those that don't have a clinical trial available to them already at their site, and what you may want to consider. So as mentioned earlier by our former colleague, obviously colorectal cancer is still a very concerning issue in the United States as well as a global issue. And more importantly, although the median age is 66, as many of you may know that follow me for a lot of my speaking engagements and my publications, I have a special interest specifically also in early onset colorectal cancer. So this is also another hot topic. And so, you know, we are well aware that the incidence of colorectal cancer is decreasing in the average age patient and in our older patient population. But the greater concern as of late is what will be happening by the year 2030, where it's approximately 49 new cases of colorectal cancer per day, notably left-sided tumors and rectal cancers. And where it is believed that colorectal cancer will be the leading cause of cancer mortality for those less than 50 years of age by 2030. So what are some prognostic indicators just in general for our colorectal cancer patient population and things we take into account in regards to treatment? Oops, I'm so sorry. So as mentioned earlier, there's a list of several things that we think about when we're thinking about prognosis and when we're thinking about sequence of therapy and what we take into account. And I think when we're really thinking about the consideration of liver transplantation as a solution for our patients with metastatic colorectal cancer to the liver, we also have to take these factors into account. And some of this is based upon some of the literature, based upon the small studies that have been conducted thus far regarding liver transplantation. But some of this is also based upon historical large phase 3 clinical trials which have noted good and poor prognostic indicators and what is the difference. So as mentioned earlier, left-sided tumors historically fare better in the metastatic setting than our right-sided tumors. We also discussed the consideration of RAS wild type. And what does that mean? Well, the RAS mutation is present in about 30 to 60% of our patient population. And if you have a RAS mutation, you cannot receive a class of drugs called anti-EGFR therapy. And those that have an all RAS wild type tumor, specifically left-sided tumors, those patients fare the best overall, and they have the most favorable prognosis. We also know that if you have the BRAF V600E mutation, which is a poor prognostic indicator that occurs in less than 10% of all colorectal cancer patients, if you don't have microsatellite, if you have microsatellite instability, stable disease, not an inherited form, not due to hypermethylation. These are poor prognostic patients if you have a mutation. So you want to make sure our patients don't have the BRAF mutation. And obviously, those tumors that are larger penetrating through, that are attached to another organ, T4 disease or perforation, those are obviously of grave concern, obviously, to us. I also like to consider histology. Historically, poorly differentiated tumors are of greater concern. Signet ring histology, mucinous tumors. So we want to, ideally, I think if we were to choose an ideal patient population, those are things I would like to take into account. And I noticed in Dr. Adam's Transplant study, which I thought was great, he took into account if the patient had a prior colonoscopy in the past 12 months. I would probably say if we're going to consider this type of consideration for liver transplantation, you may want to even reduce it down to less than 6 months. ECOG performance status is extremely important. And obviously, having good response to therapy with systemic chemotherapy, having prolonged treatment, which I think was mentioned earlier, is extremely important. And ideally greater than 1 year, as mentioned. Because at the end of the day, the very first treatment, the very first line of treatment you receive is the treatment that most patients respond the best to for the longest duration. And so historically, the time to progression following first-line chemotherapy is usually anywhere between 9 to 12 months. So if there's a patient that has a very prolonged stabilization or prolonged response to therapy past that 12-month period, that would be a candidate with a good prognostic indication. And then obviously no evidence of extrahepatic disease is always a favorable indication, I think, for this consideration, this patient population. As mentioned earlier, the size of the tumor metastasis, consideration of weight loss. And I know some of the other historical trials had mentioned a CEA at baseline less than 80. And I'm not exactly sure the premise of that other than the Oslo scoring system. But I don't know the historical data behind specifically 80. And keep in mind, a third of patients do not have an elevated CEA, so that is not necessarily helpful for some of our patients. Unfavorable indicators, once again, having a RAS mutation, having a BRAF mutation, which is a poor prognostic indicator in itself, right-sided tumors, short intervals following the completion of adjuvant chemotherapy. So meaning you had your surgical resection for your colon or rectal cancer in the past, you've received adjuvant chemotherapy, and then now you have had evidence of progression to metastatic disease within less than a year. That is actually a poor prognostic indicator as well. And obviously, any history of a second primary tumor, any lack of response to first-line chemotherapy, I think is important to keep in mind. Now, it's actually kind of interesting to me when I look at the Transmet data, which is the latest presentation at ASCO from Dr. Renee Adam, which once again included 94 patients that were randomized. They did include prior irinotecan, and as a medical oncologist, we were previously told to be wary of irinotecan because that can result in steatohepatitis, and quite a fair number of patients in both arms, in the control arm, also had received prior irinotecan. And then also there was a lot of patients that had received prior EGFR therapy. And I know that has been a concern in the past in the resectable setting, given the increased morbidity and mortality associated with the EPOC trial, which was specifically for resectable liver metastasis. But we are also aware now with our latest treatment indications that left-sided tumors, once again, we do recommend if you're RAS wild type to receive anti-EGFR therapy in that setting for unresectable patients. And thus, anti-EGFR therapy obviously may be more appropriate nowadays than we think. One thing I did find very interesting, which there's not a slide on from Dr. Adam's presentation, was that even though the patients proceeded to receive their liver transplantation, he also provided to them adjuvant chemotherapy. And this was just part of his presentation that was mentioned orally, verbally, but it was not mentioned on a slide set. So I actually don't know what percentage of patients had received adjuvant chemotherapy following transplantation. And I wasn't really sure if the purpose of the adjuvant chemotherapy was to consider any microscopic disease or any potential for extrahepatic disease during the waiting period for the transplantation. So I do think that that's something of interest, and that's why I kind of put those three bullet points under controversial. What are the current developments in colorectal cancer? I think it's really important that for all patients as well as our surgical colleagues to be aware that there are two subsets that I probably would not consider as part of the liver transplantation candidate category. So we are well aware that less than 10% of our metastatic colorectal cancer patients are microsatellite instability high. Obviously, for our young patients, we want to consider ruling out Lynch syndrome or HMPCC as it was historically known. But there's also patients with a history of the defect and mismatch repair protein that's due to hypermethylation that are average age patients that would benefit from immune checkpoint inhibition or immunotherapy. And so we are well aware that pembrolizumab is currently approved for newly diagnosed or patients that have never received prior immune checkpoint inhibition that are MSI high patients. and that is the standard of care currently. I wanted you to be aware that there's actually new literature that's very, very new that was just presented at ASCO in June, looking at the combination of immunotherapy in patients versus standard chemotherapy. It is basically called the Checkmate 8HW study. And I show you this because the pembrolizumab study from Keynote 177, which once again resulted in the FDA approval of pembrolizumab in our patient population, the response rate is about 35 to 40%, but there are patients that do have complete response to therapy. And so these are a subset of patients that have a very good prognosis, that are more than likely to respond to immunotherapy. And in fact, there are patients that can be cured with immunotherapy alone. So these are patients I would not want to consider unless they are refractory to immunotherapy. But just to also keep in mind, the most recent data shows that the combination of nivolumab and ipilimumab, which is immune checkpoint inhibition and CTLA-4 inhibitor, actually demonstrated significant progression-free survival versus standard chemotherapy. We don't have the data yet versus single-agent immunotherapy, but what this data does show is very impressive progression-free survival, much higher than the previous Keynote study, which has resulted in the previous FDA indication. But here we're reaching progression-free survival, which has not yet been reached with the combination immunotherapy versus standard chemotherapy. Once again, this is MSI high patient population. And that is, oops, I am so sorry. This is very sensitive. And also in the control arm, there was crossover of 69%. So the primary endpoint here is progression-free survival. The secondary endpoint is overall survival, which is going to be impacted by the crossover arm. So at the end of the day, the results are very, very impressive. And we will obviously learn more about the final results of this trial moving forward. There is another patient population. I am so sorry. I don't know why my mouse is so sensitive. There's another patient population that I think we should also be very cautious of as well. There's the HER2 amplified patient population. So many people are familiar with HER2 amplification, which is a standard of care for testing in breast cancer and gastric carcinoma. We now know that in metastatic colorectal cancer, it is less than 5% of our patient population. And now we have tucatinib, which is a tyrosine kinase inhibitor, specifically of the HER2, in combination with trastuzumab. And so this is in previously treated patients. This is a very impressive study called Mountaineer. And once again, these results were specifically more noticeable in patients with either HER2 3+ by immunohistochemistry or HER2 2+ by immunohistochemistry, but amplified by on FISH. And so basically, this is an oral agent in combination with trastuzumab, and they reported a response rate as high as, and this is a very refractory patient population, about 4 prior lines of therapy. So response rate about 40%, progression-free survival of 8 months, but a median overall survival of 24 months. This agent has now moved forward to the front line setting in a clinical trial called Mountaineer 3. So I suspect once we have those results, we're going to see very, very significant benefit. So I would say that in this patient population, I would not allow patients to participate in the consideration of a liver transplant unless they have demonstrated refractory disease to HER2 directed therapy. So what would I consider in the consideration of clinical trial development? These are, I know this looks like a lot, but these are the criteria that I would really think about. Once again, you want your unresectable patients, you want your left-sided good prognostic tumors. I would not include MSI high patients, but only MSI stable patients, your non-HER2 amplified patients, unless, of course, they have demonstrated progression of disease to both of those agents. And all RAS wild type tumor, because there is historical data that's been published, as well as I've published on it, regarding the difference in outcomes if you have a RAS mutation versus a RAS wild type in resected liver metastasis. Once again, you don't want a BRAF mutation. That's a very poor prognostic indicator. If the primary tumor is intact, I'd be very cautious about clinically bulky tumors or N2 tumors potentially. So I would definitely want a non-bulky tumor, non-N2 as your, based upon a post-op pathology, and obviously a non-obstructing tumor. And obviously histology, I think, is important. And once again, the size, the liver metastasis, good performance status, I would obviously like to see prolonged benefit to systemic chemotherapy before proceeding forward, not going through multiple lines of treatment. I probably would not allow more than 2 lines of therapy. And once again, the question about the CEA, I will leave it up to the liver surgeons, but I'm not really historically sure where that data comes from in regards to baseline evaluation and the negative PET CT scan. One thing that I would like to comment on the Transplant study, they did not collect patient-reported outcomes. So I would encourage anybody that writes these clinical trials moving forward regarding liver transplant to consider PROs. I would highly recommend the consideration of circulating tumor DNA for MRD or molecular residual disease or minimal residual disease. That is what I do as a standard of care for all my liver resection patients currently. And then please consider that this is a consideration of a liver transplant. So they're always at risk for second primary tumors due to the organ transplant in and of itself. Patients are at risk, for instance, for anal carcinoma moving forward for any organ transplant patient. So there are risks and benefits, and I just want to make sure that people understand to please consider participating in a clinical trial to support these efforts so we can learn more. Obviously, the Transmet data is very, very intriguing, but it is 94 patients, and I think we need to capture more data. And thank you for your attention.
Thank you so much, Dr. Eng, for such an excellent overview of oncology part of it. I certainly learned a lot, and I think the whole science community is very excited for the new therapies that are yet to come for our patients. And I would like to introduce our next speaker, Dr. Carrie Thiessen, who's an abdominal transplant surgeon and a bioethicist at the University of Wisconsin-Madison. She is a member of ASTS and TTS Ethics Committee and recently completed a term on the OPTN Ethics Committee. She currently serves as a co-chair of AST's Psychosocial and Ethics Community of Practice as well. Her work combines normative and empirical methods to evaluate and optimize patients' and providers' decision-making about risk. Among other topics, her research quantifies living kidney donors' willingness to accept risks, evaluates the impact of living donor non-eligibility, and examines the experiences of individuals who opt out of living donation. Dr. Thiessen, thank you so much for joining us today.
Thank you very much for that kind introduction. And thank you to the AST for the invitation to speak today. I'm going to try to move relatively quickly through my slides so we have time for questions. I'll say that most of my comments are framed specifically about living donor liver transplant for recipients with colorectal liver disease, metastases, but they're broadly applicable to living donor liver transplant for novel indications or in cases of high risk recurrence disease. And while I primarily discuss the living donors, there is some degree of consideration to ethical considerations related to the recipient. I have no financial conflicts of interest to disclose, and today my presentation reflects only my own views. So some of the initial principles to help guide the conduct of living donor liver transplant were promulgated in the Vancouver Forum. Even though this Vancouver Forum guidance document was published about 20 years ago, it's still highly relevant today. In the interest of time, I'm not going to read the quotes that are on the slide here. I will just point out a few key things. Number one is that there is recognition that there are 2 patients that need to be considered in the ethical assessment of living donor liver transplant, that there may be tensions in balancing competing principles of non-maleficence in respect to donor risks and beneficence in respect to recipient benefits. The Vancouver Forum also acknowledges that novel indications for living donor liver transplant should be introduced under clinical trial protocol, which was done in this context. And that last point that's on the slide is really in recognition of the fact that there's risk to living donor, that living donor transplant should be offered to recipients who receive some extra advantage out of living donation relative to receipt of a deceased donor organ. And given the historic low MELD scores of the population of patients with colorectal liver metastases, I think that the criteria was met in these clinical trials. So looking more at this balance between risk to the donor and recipient benefit and a determination of when living donor liver transplant is ethically permissible, Mark Siegler from the University of Chicago came up with this principle of double equipoise. And this is a conceptual figure that he has to demonstrate when there are permissible risks to donors and permissible benefits to the recipient. So he argues that above a certain level, and this is just meant to be risk of mortality to the donor based on his initial paper, that risks to donor above a certain threshold are never acceptable, and that there must be a minimum threshold of benefit to the recipient that's met to allow a living donor to assume some degree of risk for the benefit of the recipient. And that there are these extensive gray areas where the risk to the donor or the benefit to the recipient are marginal. So I'd say overall, this is a very robust conceptual model. My goal in the next few minutes is really to highlight other donor and recipient considerations that are specifically relevant to the determination of double equipoise in the context of colorectal liver metastases and transplantation in those contexts, and then point out specific aspects for evaluation that are unique to this population that we need to consider further. Okay, so when we think about the donor risk side of things, the physical risk of undergoing living donor hepatectomy is unchanged compared to other indications for living donor liver transplant. But we could imagine that the benefits may be different and the psychological risks may also be different. And I would say that implicit recognition of the importance of these psychosocial risks and benefits was embedded in the fact that many of the centers who initiated these protocols for living donor liver transplant in this population of recipients did not use or accept non-directed donors as part of their protocol. I'm just going to draw attention to this great work by Peter Rees and his colleagues that argue persuasively for expanding how we think about living donor risks and benefits. They argue that there are benefits to the donor that are real and should be taken into account, whereas conventionally they were not taken into account. And there are harms of non-donation that are equally relevant, and that we should be thinking about not just the physical harms, but also non-physical harms and benefits. And here, this is just a list of some of the non-medical benefits of donation that they talk about, including reduced caregiver burden and potential financial benefits in terms of restoring income for the recipient who could potentially return to work, or allowing a caregiver to return to work. And then this is some of the non-medical harms that they discuss of non-donation. So feelings of emotional distress, not being able to donate, and loss of control and impact of the recipient's disease on the potential donor's lifestyle. Here, I just have a few quotes from some work that I've done with living kidney donors. There's relatively little data about details of how the living liver donor population thinks about decisions about risk acceptance. And so this is work that we've done with 282 living kidney donors. And I just want to point out some of the complex things that people are thinking about as they're making decisions about risk acceptance and who should make decisions about permissible levels of risk. So in the interest of time, I won't read the quotes, but I'll just say here, people are appealing to the psychosocial importance of close relationships. They're talking about the urgency of the need of the recipient. In other quotes that we have from this data set, people talk about the significant value to them of the relief of anxiety or stress in knowing that their loved one would receive a transplant. And people are also thinking about different kinds of trade-offs. So trade-offs about who lives for longer periods of time. And I think this first quote is pretty interesting in that this person is appealing to some sense of a fair innings approach to that everyone should have a certain number of years of life. And then the second quote is really talking about value that they place on the needs of certain people to engage in caregiver roles and be part of their family. So it could be argued that another aspect of thinking about the risk-benefit ratio for the donors is that there's some special psychological impact of the risk of recurrence of disease in the recipient. And here's just some data about the risks of recurrence that we have from the literature so far. I will say, however, that we already permit living donor liver transplantation for other diseases in which there is a risk of recurrence, although that risk of recurrence could be lower, like cholangiocarcinoma or hepatocellular carcinoma. But we also allow living donation for patients with alcoholic hepatitis, where the risk of recurrence may not be all that different at 5 years. But we actually don't know that much about the experience of living donors whose recipients have developed recurrent disease. And that's something that it would be useful to learn more about. Thinking more about this other component of double equipoise is, thinking about the recipient benefit risk ratio. And as many others have noted, there's need for careful recipient selection to maximize the potential for benefit to the recipient and minimize the chance of performing a futile intervention. And the relative advantage of receiving a living donor liver transplant may partially be dependent on whether the intended recipient has some degree of hepatic dysfunction and a higher MELD score, or if it's primarily for oncologic advantage, and they would be listed with that median MELD of -20 only. And then just pointing out again that we have limited data on long-term survival, so there's only so much that we could say about the degree of recipient benefit. Okay, so in conclusion, to thinking about double equipoise, I'd argue that on the donor side, we should be thinking not just about donor risk, but also donor risk and benefit. And on the recipient side, we need to think about benefit and risk as ratios. So now that we've established that there are circumstances under which we think that living donor liver transplant for colorectal liver metastases might be ethically permissible, we need to think more about what informational needs living donor candidates have. And in general, we know that there's not that much that is documented about this. There is OPTN policy that specifies that transplant candidates who may have increased likelihood of adverse outcomes, the options are you don't disclose the specific details to living donor. You just say generically that any recipient may have some increased risk of an adverse outcome, or you could get consent from the recipient to share details about their health, disease course, and or prognosis with the donor. So special considerations in living donor evaluation informed consent for this population. I talked to several of the centers who have been doing these studies. It sounds like there wasn't any specific evaluation component that was unique to the living donors that they applied, but one could consider extra screening for psychological resilience or minimizing the potential for people to have some degree of decisional regret. Of course, this point may be less relevant as we get more data and transplant for colorectal liver metastases becomes an established treatment option. But for the initial studies, there was disclosure that it was a non-standard of care indication for transplantation. And of the centers that I talked to that engaged in these early studies did get the recipient's permission to disclose their health information to the donor to help the donor understand what the situation was and also help the donor understand some aspects of the timing of their evaluation. So I point out that thinking about the optimal timing for the donor evaluation is important because we know that evaluation imposes burdens to living donor candidates. And also some people have gone through the evaluation process and then were ultimately unable to donate because of issues related to their recipients' well-being. On the kidney side, where we have more data, have felt disappointment or guilt or distress that their hopes were raised and that they ultimately couldn't help their loved one. And I just reinforce the need to discuss the option of opting out at multiple times throughout the process. We do have data that up to 35% of living kidney donors do not recall that they were given that option. I would say that the studies that were done on living donor liver transplant for colorectal liver metastases, most of them did not consider the living donors as research subjects. And I'd argue that this is a missed opportunity and also that the donor and the recipient were both components of this intervention to engage in an untested treatment for colorectal liver metastases. And just as we don't know the outcomes for the recipients, we equally don't know the psychosocial outcomes for the donors. And I'd argue that both of them should be considered research subjects. One of the studies that was listed in clinicaltrials.gov did in fact include the living donors as clinical trial subjects. That was actually the study that was done at the University of Wisconsin-Madison. I can't take any credit for it. The IRB approved this and reviewed it before I arrived at the University of Wisconsin. But you could just see here the eligibility criteria that were listed. And even though the donors here were considered subjects, there wasn't a detailed plan for qualitative evaluation of their experiences after donation. So I'll just point out briefly, this is a figure from one of the articles looking at the flow sheet of candidates for a living donor transplant on the recipient side. But I pointed out just with these yellow stars, a few opportunities for where we might want to consider special components and experiences of the living donors. So at the evaluation point, in parallel, we would want to know things about what the mix of a relationship is for the people who are presenting as potential donors, what their rates and reasons for opting out are, to see if they're different from the general pool of living donors. At the post-approval stage, if they experience psychologic distress, if their recipient has disease progression and is unable to proceed with transplantation, and after donation, the impact of recipient disease recurrence and decisional regret. So in conclusion, I would just say that we have these balancing of the needs of the donors and the recipients in consideration of living donor liver transplant for non-resectable colorectal liver metastases. It requires careful selection of both the donors and the recipients. There are these aspects that are unique to evaluation-informed consent that I've pointed out. Future clinical trials involving living donation for experimental indications should consider both the living donors and the living donors and the recipients as research subjects. And we need further research on the experiences of living donors for patients with these indications and other innovative indications for living donor transplantation. Thank you.
Thank you. All three talks were really, really excellent. I feel like I have information overload. So we don't have tons of time for questions, but we wanted to ask a few. I think as you've all pointed out, this is a rising indication, and there are many centers that are already doing it, not very high volume like Dr. Hernandez's center, but starting to make protocols. So just wanted to ask each of you kind of hard no's. I think you both, Roberto and Cathy, gave excellent reviews on what you would do at your center. But if I can ask for Roberto, so absolute interval from diagnosis to transplant and resection of primary to transplant, and how often you use PET scans. And then for Cathy, what lines of treatment would you say is absolute, where you should absolutely not progress over? And I know the CEA, if you weren't considering the CEA, would you look at Signatera trends? And then for Carrie, as far as recurrence, what you would define maybe as unacceptable, or I've noticed even in Wisconsin in the previous study, you showed that non-directed donors are not being considered, and why that is that necessary? I know that's a lot, but I think those would be helpful just for people starting protocols to really know. Whoever wants to go first. Roberto, I guess I asked you first.
Okay, thank you. It was great opportunity to hear what Dr. Eng and Carrie mentioned for answering your questions very quick. So number one, yes, we do PET scan in every single patient. We do PET scan and we do the MTB score. And if it's above 70, we don't do it. If it's below 70, we do it. Now, for those patients who Dr. Eng showed, very similar of what we do is if they have no high risk, multiple mutations or a lot of mutations, or left side colon, which those patients, the observation period of time from diagnosis of colorectal metastasis to transplant, minimal 12 months. Now, colon resection, 6 months or more. About from that, that's our criteria. In patients who have higher risk, such as right side tumors, or patients who have KRAS and TP53 mutation, for example, then we will observe 18 months, year and a half. And we have to see that they are not progressing at all. Something that Dr. Eng mentioned that I like is about where does it come below 80. I think that was the multivariate analysis from Oslo. However, for my group, it's more important. Of course, we want to be below 80 or below something. We have never done someone close to 80, but it's more important to see that it's not going up. Because if I have someone who has 16 and then it has 25 and then it has 35 and then 60, that's below 80. That patient is progressing and I'm not going to be transplanting it. So that is my answer, and hopefully that resolve your questions.
Great.
So I guess I'm the next person to answer your questions regarding what lines of chemotherapy I would consider, and is there a role for circulating tumor DNA in that setting? I would definitely say, as mentioned earlier, doublet chemotherapy for left-sided tumors with anti-EGFR therapy is considered a standard of care with a very high response rate, but there's no head-to-head comparison to FOLFOXIRI plus bevacizumab. That has a really high response rate, about 65 to 75%. But if I've given a patient, and this is what we tend to do sometimes in our young patients because they can tolerate FOLFOXIRI better, if they progress on FOLFOXIRI on my frontline therapy, I would highly not recommend them for a transplant. I had a patient actually that went to Cincinnati, and she had progressed very quickly on her FOLFOXIRI within a matter of 4 months. But she still wanted to go see the surgeon. Of course, you can't deny a patient that. And there was a lot of back and forth discussion, and it was a bad prognostic indicator. In fact, she never went to transplantation. She continued to progress at other sites. So I would say a patient that progresses within a short time period, even with just FOLFOXIRI alone, that's a bad prognostic indicator. In regards to doublet therapy, I think you can do FOLFOX or FOLFIRI now. It seems like there's less concerns about steatohepatitis moving forward now based upon this recent data. And in regards to circulating tumor DNA, I think it is very reasonable, but I think it's very important to keep in mind, and also because it's helpful because not all patients have an elevated CEA. It's also important to keep in mind that circulating tumor DNA varies based upon the site of metastatic disease. So you may have a patient with a lung met, but it's not going to be picked up in the circulating tumor DNA because actually the liver sheds more than the lungs. And historically, lung mets do not have necessarily positive circulating tumor DNAs. So just because the circulating tumor DNA is necessarily clearing, it doesn't necessarily mean it's cleared everywhere. So it's not 100%.
That's a great point. Thank you. And Carrie.
Yeah, so I spoke to people at 3 of the centers that were enrolling living donor liver candidates for recipients with colorectal liver metastases. And all of them had independently decided not to allow non-directed donors to participate in their clinical trial. And I think a lot of the underlying reasoning behind that is that it's unknown how people might respond if there was recurrence or decreased survival among the individuals who received liver transplants. But for people who knew their intended recipient and were perhaps family members of their intended recipient, there would be some degree of psychosocial benefit that could counterbalance those unknown risks. And in terms of what level of recurrence might be unacceptable, I think part of that is dependent on recurrence versus survival. And, recurrence is not the only thing that maybe matters to both the recipients and their potential donors. So I think we need to distinguish between those things. I think we also need to ask potential donors what their opinions are about levels that might be acceptable or unacceptable to them.
I think that's so important, and we try to say that all the time, and we do transplant oncology as well, that recurrence, we accepted hepatitis C had 100% recurrence before we had cure, right? So this is not, I totally agree with you changing that conversation about recurrence. Roberto, do you have a quick question or comment?
Yeah, I have a quick comment because there was a very important point that Dr. Eng mentioned about why in the trial of RCT with Dr. Hernandez, they use chemotherapy after transplantation. Only 65% of the patients received chemotherapy. The other percentage of patients were not able to receive chemotherapy because they were recovering, because they have a bile leak, because they have something. And my question to him was, were you able to analyze the difference in survival or progression-free survival of those two populations of patients? And he said that there was no difference. My guess is that he wants to do a second RCT without chemotherapy. That's what I think so. And I think he did it with chemotherapy because that was the standard of care of using chemotherapy. I think nobody else is using chemotherapy after transplantation. And I don't see too much sense of doing that. And an interesting, another point very quick of that circulating tumor DNA, we followed that. We were working with a company where and they have this garden thing that a lot of and after transplantation, there's a lot of differences in the results that is creating a lot of confusion. So I personally think we switched that completely to use Signatera because it's just a simple single level, and that's what we're doing. We are collecting the data. Hopefully, we can have something strong to be able to report it and to publish.
That's very fascinating. Thank you for sharing that.
Right, and Signatera you're using like every time with imaging, I assume? Is that how you're?
Yeah, Signatera, we do it pre-transplant, like a few days before transplant, and then we do it every 3 months.
Yeah.
After transplant.
And maybe just one last question, if possible, just to piggyback on your post-transplant management of these patients. Can you comment a little bit more, and this is a question for Dr. Hernandez, on management of immunosuppression? In a lot of studies, there was a use of basiliximab with or without the steroids. There's a question of transition to an mTOR inhibitor early on. So what has been your experience with immunosuppression?
Fascinating question, Alex. So definitely, we were afraid of the cancer, and then we tried to taper the immunosuppression down. We started with basiliximab, and then with TAC and MMF, and then we tried to switch them later on to mTOR inhibitor. A lot of the patients, especially living donor, you know that they can have bile leaks or complications, so you have to delay the mTOR inhibitor. But something that we saw is much more rejection in this population of patients. I don't think it's the cancer. I think is look at them. They are so young. They are 30s, 40s, and they are super healthy. They are not the cirrhotic patients that we used to treat. So that, I think that's what we reject. So we went back to the normal chemotherapy that we use in our HCC and cirrhotic patients. And of course, after 3 months, we try to change it to mTOR inhibitors if there's no complications. So far, we have been doing very well, and we haven't seen any abnormality. I'm happy to share our protocol at any time.
Would you consider, I mean, one of the things we do mostly for cholangio, we've only done one colorectal, is low-dose mTOR. I'm sorry, low-dose TAC with mTOR. And
Yes.
we haven't really had any rejection with that at all. But or are you saying you completely switched to mTOR?
No, as it's very similar of what you're describing, Anjana. So mTOR with TAC, with low-dose TAC.
Yeah, I think you're absolutely right. They reject, and then you're just in a bunch of trouble. You're then giving a high dose of pred. And all right, this was so wonderful. I hope you guys, we really enjoyed this and so much information. So really appreciate you all spending your time with us. I'm sorry we're a few minutes over, but we had so many questions to ask you all. Brian, take it away.
Well, thank you so much. AST would like to thank our COP sponsors, LICOP, LDCOP, and PSECOP, as well as our panelists and all of our attendees for today's session. Please remember to complete the evaluation survey at the close of the webinar, and thank you all for attending.